Hello, everybody. I'm Dr. Annie Peters. I'm the Director of Research and Education for NAATP, and I'm going to be doing a series of question and answer sessions with some prominent researchers who have developed online or developed measurement tools that might be useful in your practices, particularly now during COVID-19, and also for anyone using virtual services, but not just that. These are tools that are available for any treatment center, any provider who wants to do some data collection, whether it's assessment or progress measurement or feedback gathering for their practice. Today I'm talking to Norman Hoffmann. Hi, Dr. Hoffmann.
Good morning.
Dr. Hoffmann, a little bit about you. So you're a clinical psychologist and definitely a well-recognized expert in the field of assessment of mental health and substance use disorders, and founded CATER, which remains the largest independent outcomes research system in the addiction field, has a database of over 75,000 individuals with substance use disorders. And currently you're an affiliate professor of psychology at Western Carolina University and founder of Evince Diagnostics, LLC. So Dr. Hoffmann, could you just tell us briefly which of your tools you think might be particularly useful for NAATP members or addiction treatment providers during this time of COVID?
Well, the two tools that I thought might be helpful are the TAD5, which is a brief 10-minute triage tool that can be administered over the phone or in person. It identifies those individuals who do not have a problem or officially meet a diagnosis, those people up in the severe range, and those people who might merit some further assessments. For example, with DUI offenders, our research has shown that about half of them first-time offenders don't meet diagnostic criteria because the only thing they have is the driving while intoxicated or under the influence. About 10% or so of those first-time offenders, however, show up over in the severe range. And the remaining 40% or so fall into the mild to moderate range, which might, in some cases, be able to successfully moderate use or not, depending on further assessment.
So is that something that would be a good tool to use maybe during a pre-admission assessment where you're trying to determine the level of care, whether the person needs residential treatment or outpatient treatment?
That's precisely it. It would be an excellent way of triaging people up front as to whether they might be appropriate for a program or not. If you're running an intensive residential program, obviously the ones without a diagnosis would not be appropriate, but probably also the ones in the mild range would not really qualify with the ASAM criteria for a residential placement. The other tool I thought might be helpful in achieving some modicum of distancing or minimizing exposure is the CATE5. The CATE5 is designed to do a detailed assessment of substance use disorders, but also to identify those areas in mental health that are frequently found as co-occurring conditions, such as depression, PTSD, and the like. And the way it would minimize exposure, or could be used, it's administered on a tablet or PC, or even a phone. A large smartphone would be appropriate as well. What I was envisioning was if you had it on a tablet, there is an option where after the information and demographics are entered, the personal identification and demographics are entered, the person doing the interview could click on an option for a computer administered option. At that point, the tablet could be handed to the respondent or patient. They could go off and answer all the questions by using click buttons and drop downs. When they answer the last question, the whole system locks. And at that point, the person could return the tablet to the person doing the interview or the staff person monitoring it. at which point the staff person could use a disinfectant to wipe down the tool or the tablet and enter a passcode that would give them access to download the PDF file and print out the report. So that would be one way of reducing the amount of time people spend face-to-face with somebody prior to admission, probably at the intake point, and possibly also when they would be being evaluated for appropriateness for admission. Toward that goal, the CAPE also informs dimensions 1, 3, and 5 of the ASAM criteria. In terms of recency of use, obviously the mental health conditions are covered, and also certain variables that we have found to be associated with relapse and prognoses are included for dimension 5.
Okay. And I know when we were talking about this, you had mentioned that the CAPE 5 might be useful if programs have a mental health track or just an addiction track, a co-occurring capability, that the CAPE 5 would be good to determine if that person were really in need of a more co-occurring capable program.
That's correct. Whether you're dual enabled or dual capable, it would be a good tool to sort that out as well. And also could be used during the course of treatment to verify that some of the mental health conditions are resolving, like depression. There are less criteria being met, or things that crop up that the individual initially either denied or did not consider to be important to mention. So it could be used in that kind of a treatment monitoring mode as well.
And I know we had talked about the fact that typically with particularly assessment, not as much screening, but particularly with assessment, the face-to-face is often what clinicians really want most. And but at this time, when we're trying to sadly keep that at a minimum and reduce our exposure, especially at the outset, this might be useful.
Well, it could be also used in a way that you would do it as a preliminary determination, because the output, the PDF file that it generates, does not only indicate the level of severity that was indicated based on the number of positive criteria for each of the conditions covered, but it also has the actual item responses also that print out as sort of an addendum to the report. So the clinician could then review that information with the patient to verify that indeed these are the positive findings, and this is based on whatever other information the clinician may have are conditions that need to be addressed during the course of treatment. Also, I might mention that both the TAD and the CAPE save all the item responses on a de-identified file for evaluation or research analyses, so that if you were using the TAD as an intake tool or as a pre-intake screener, we could provide reports on what percentage of people hit what level of indication of a problem. With the CAPE, we can also produce a report that not only looks at the substance use disorders, but the prevalence and severity of the mental health conditions that are found in your population. So that might guide people at the executive level of looking at what type of staff qualifications do we need for the patients that we're now seeing, so that if you're getting a large proportion of people with, say, PTSD indications, which are highly likely given our current situation, then you might want to make sure that either your current staff are up to date on dealing with PTSD, or you might be looking for some additional staff to supplement the staff you already have.
And the TAD and the CAPE they're not new tools. They have research behind them. Do you want to say something about those?
Yes, they've been available in paper form for years, dating back to at least almost 20 years, give or take, depending on the instrument. they've been available in paper form from the change companies, which they also produce the interactive journals. And so the tools have been available there for a long time, as well as some of the other tools that we've now automated, like the PADI-5 for evaluation of adolescence, and the SUDS-5, which also captures age of onset for all problems. So that could be valuable for motivational enhancement or helping an individual appreciate how his or her problem evolved over time. We haven't yet automated any of the tools that are based on the ASAM criteria, but we first wanted to get the diagnostics down. The programming for doing these and presenting the questions the way a clinician would present them is a complex programming challenge. You cannot do this with SurveyMonkey or programs that just do a straight through, because the way that especially the CAPE 5 asks the questions is dependent upon what previous answers you have received. So you don't do your drill downs immediately, but you first find out what positive criteria might be present and then drill down from there as to which substances might be involved. So the two tools guide the interview, if you will, in the same way that an experienced clinician would. That also means that you can use other staff conceivably for doing the administration part. And then pass that information on to your clinicians, who can then have the credentials to make whatever diagnosis needs to be made and other treatment decisions.
And you put these tools, you automated these tools and have them online through Evince Diagnostics. That's been, that has been more recent, right? Since you said last year?
Yeah, we just went online at the beginning of this year, really.
Okay.
So the programming was more of a challenge than the programmers had anticipated. So we had anticipated being live about 6 months ago, but as it turned out, we just went live online just prior to the COVID-19 hitting. So yeah. We thought, well, what could we do that might be helpful to programs? And we thought, well, these two tools actually might help reduce exposure or might facilitate gathering information a little more upfront from where the patient would normally hit an experienced clinician. And since they're totally guided interviews, as long as you can read the questions off the screen and record the patient's answers, you can do the administration.
Well, thank you. And I know you wrote up a short description of the tools and how to access them, and the special offer you're offering for people who see this video are NAATP members. And that's much appreciated. That's really helpful for anything we can offer our members at this time is great. So
we thought we'd offer some free introductory uses of the instruments, just to see if people found them useful in the context of what the COVID virus is doing for us and to us. So whatever help we can give to providers, we're here to try and help.
Wonderful. Okay, and then if people want to start accessing these tools, they just email you?
Yes, they can email me most efficiently at norman@evincediagnostics.com, and they can get a hold of me. Also, I have a cell phone number that they can use. It's 401-374-0375, and that's usually on my hip most of the day.
Wonderful. That's great. They can just access you that easily. So thank you so much for your time today and for offering this to our members. And your time is much appreciated. Thank you.
My pleasure.